This program has been made possible in part by the following sponsors. The Trial Lawyers Association of BC. The Vancouver Courier newspaper. My new book about addictions, All the Way Home, Building Recovery That Works. We are aging as we look at each other this evening, and it's not just us, boys and girls, it's all of Canada. The demographic is skewing towards an older population, and that brings a lot of considerations, particularly in terms of the quality of healthcare and, of course, the cost of healthcare. How do we respond to our senior citizens, especially senior citizens who start to lose some intellectual capacity and so on? Well, there are a lot of different ways, and Dan Levitt, who is the executive director of Tabor Village out in Abbotsford and has been working in this area for a great many years, had the wonderful experience recently of visiting a unique new version of how to deal with seniors in the Netherlands. And he is also, of course, an adjunct professor at Simon Fraser University and an old friend. It's great to have you here, Dan.
Great to be here, David.
Yeah, what an amazing journey you had. What happened? You just read about this and said, I have to go look at this place?
Well, as you can imagine, yes, we all know in the industry, we know that there are some places that are doing things far beyond what other organizations are doing.
Right.
And the De Hogewey household community in Wisp, Netherlands, yes, is leading the way, and they're really ahead of the pack. And I knew about it. It's a well-known organization, yes, and I was lucky enough to be there for an international conference where I was speaking and got a chance to tour the site while I was there.
What were you speaking about?
I was speaking about innovation and leadership.
Well, there you go. So just give us a description, because it sounds, the more I read your report about it, the more I want to move in. I mean, it sounds idyllic.
It is idyllic, and
yes,
the city it's located in, Wisp,
yes,
is this amazing place. It has all the typical things that you'd imagine, yes, that a Dutch community would have.
Yes.
As well,
yes,
there is this neighborhood that's sectioned off, looks like the other buildings in the community, but yes, that particular neighborhood, though it is locked, within that environment, the people who live there, yes, who all have dementia, yes, they can roam freely and they have choice in how they live, which is a different concept than how we traditionally have cared for people with dementia.
And when you say they roam freely, you describe that, for example, they live only 5 or 6 to a living unit, to a sort of cottage, and they get up and they make their own breakfast, which lots of people with dementia don't do. How do they know? How do the people who run this operation know that these folks are going to be able to do that?
So what they have is they have some care workers who are, yes, living there. They're multi-skilled workers. They do everything. They'll help them get out of bed. Yes. They'll help them get dressed. They'll help them in the toilet.
Yeah.
And as well, they come together in the dining room. They decide what they want for breakfast.
Okay.
And they might know their individual preferences.
Yeah.
But then they also decide together what they want to have. And not surprisingly, pancakes is often on the menu.
Yeah.
But then imagine.
Isn't that where you and I always meet for coffee, at the pancake joint? Yeah.
A great place.
Yeah. Yeah. Yeah.
And so they'll have pancakes just like you and I would,
yeah,
and then over the breakfast, lunch, or over breakfast they'll discuss what they want to have for lunch. And one of the residents, one of the seniors, will go, perhaps with a companion, yes, go to the local supermarket, which is only a short walk away, yes, within this community, and will purchase the necessary ingredients for the meal the rest of the day.
I don't think I didn't get that when I read this piece of yours. The supermarket is actually contained within this kind of village. Okay, so they're not going to the general supermarket where there's 66 other kinds of people.
No, so it is a protected environment.
Okay.
And they go in there, but it's just like your classic grocery store. It has everything you can want. The first thing you see there is a glass chest freezer full of ice cream.
Oh, perfect.
Right, so it's the ideal
Yeah,
supermarket. There's a newsstand right next to it. There's a flower shop, and inside there are all the ingredients they need, as well as incontinent products and medical supplies, and they'll buy those for the neighborhood. And with the aid of the supermarket cart, they'll wheel themselves back to their community, and they'll restock the pantry, and that's their meals for the rest of the day.
It's interesting that you said there's a newsstand. Do many of these people who are a bit Alzheimer-y already, do they want to buy papers or magazines or books?
I think the whole idea is about normalizing the environment for seniors with dementia. We have an idea of perhaps an old, different kind of model that we're used to. It's an institutional model. This is a different model where it's all about choice and freedom, and they think that that will lead to better health outcomes. And from my observation, it does.
It does. What did you see? You saw people who looked more content, or they were friendly and saying hi, and
So right across the hallway, or the marketplace hallway from the grocery store, is an art studio. It's called the Rembrandt House. Inside the Rembrandt House, there are seniors in the morning who, with their cup of hot beverage, they're painting, and so they're just like a Van Gogh or a Vermeer themselves, and they're painting these beautiful pieces of artwork while they're sipping their beverage. When they get to the bottom of the beverage and they've lost attention and they finish their work, they leave, and somebody else goes in there and kind of takes over from where they were. They go on to their next activity.
And there's lots of activities. There's music and some physical activities, and Dan, is this a private operation?
It's a private operation in the sense that it's run by a nonprofit organization that runs other facilities. It's funded a very similar model to other nursing homes in the Netherlands. And not unlike facilities in Canada.
Now, I don't know the Netherlands social system, but I'm guessing just off the top that it would be not quite Denmark or Stockholm, but close to it. In other words, it's a very socialized community.
It's a socialized model, a universal coverage, similar to what we have in Canada. And they also have the same kind of cost pressures and tax-based issues that we have in Canada.
But in countries like Denmark and Sweden, you really have a sort of cradle-to-grave funding arrangement. That's the model there. And consistently in studies and polls, people in Denmark are called the happiest people on earth, which is kind of funny. Taxes are high, but for example, if you and your lovely wife had another child, you could take a paternal leave, and still go to school, or be paid to stay home.
So it's a very rich system. Looking at that perspective. And my understanding is that there's only so much money that is available to spend on the social safety net. So we have to decide as a society where our values are. And my bias in my industry is towards seniors care, and I really think that is one of the big societal questions: is how much of our tax base are we willing to put towards seniors, especially, as you mentioned in the opening of the show, all that pressure on the system, because we're going to see the doubling of the population of seniors and the doubling of the number of people with dementia. So how are we going to grapple with that? And we have to look to models like the Dahogaway household model as solutions to consider when we start to grapple.
Do they actually call it a dementia village?
They call it dementia village. That's the colloquial term. In the industry, they call it that. I don't speak Dutch, so they might have called it something else. But the brand name, if you will, is Dahogaway.
Okay. So can we afford it?
So big question. I believe you can afford it. They did have a grant to help reduce the capital cost in terms of amortizing the building cost. They had a grant towards that, so that helped reduce some of the pressure. But I believe we can afford this, just like we can afford the kind of facilities we're building right now. I don't think it costs any more, and it certainly doesn't cost any more to run.
What's your sense? Is Tabor a privately owned, a for-profit, or not-for-profit? What is it?
It's a not-for-profit. We're a faith-based organization. We have support from the Mennonite Brethren community in Abbotsford. We have 11 participating congregations.
Do they know that a Jew is running it?
They do now.
Okay. I hope you don't get fired tomorrow.
No, they're a wonderful community, and I come from a faith community, and I love working in a faith community. It's a great organization. But what I can tell you is that we have a 55-year-old building. And there are other old facilities out there, lots of old bed stock, and we're going to have to replace those facilities and make them to the current standards that are out there.
This can be an extremely expensive proposition, running these kinds of facilities. When you and I think when we first met so many years ago, you were working here at Harrow House.
Harrow Park Center.
Harrow Park Center, right, just a few blocks from here. That's a big, big program. And not to, I don't want to diminish it because people do wonderful work there, but it is a very institutional kind of setting, you know, rather hospital-like bland hallways and you know, dull paint and so on, you know. But this kind of thing that you're talking about has a sense of being more human, more lively, and more immediate.
And that's what you want. And if you look at other parts of the healthcare system, for example, when my mother had breast cancer, I went with her to the BC Cancer Agency, and I sat with her in the waiting room before she had radiation. And in that room, it doesn't feel like a hospital. It feels like a very special, welcoming place where it might be like a living room in your own house.
Yes.
And that's what we should be looking at is changing the mindset of what you expect to have. You expect to have a nursing home that looks like an institution.
Yes.
Where if it's 11:40 in the morning, the care aides wearing their hospital scrubs are rushing down the hallways.
Yes.
The hallways have shiny floors and fluorescent lights. And they're rushing down to get to the meal on time to make sure that all the residents are sitting there so the staff can serve them a meal. And that's a different kind of model than having a staggered mealtime where you can show up to the lunchroom when you want, or the dining room when you want, and you can choose the menu items that you have, and you get to enjoy it with sitting at a table with people that you know.
Now, how is the management able to do that? I agree with you. I think that's a wonderful setup, but it must be a challenge for the people behind the scenes who are. I mean, how do we? We're not a diner. How do we decide we're going to make? You know, we're going to make chop suey or latkes at 2 in the afternoon.
I would love to have chop suey with latkes. That'd be delicious.
Sure. Yeah.
Well, I visited recently a facility in Kansas. I was
in Kansas.
Speaking at a faith-based community.
We're not in Kansas anymore, Dad. Click your heels, baby.
but so imagine like the opening scene from The Wizard of Oz. You open the door, and this is what happened to me. I woke up in the morning. I met the administrator at the large dining room table where all the residents were sitting together in this one unit, this one household neighborhood.
Yes.
Just like the Hogaway in the Netherlands.
Yes.
And he says to me, Tim says, we can have whatever we want for breakfast. What would you like? I asked, I'll say, I'll have what you're having. He says, no, order what you want. And I said, okay, I'm going to have
He doesn't
pancakes.
know you very well. You always say, I'll have what you're having. Yeah.
It usually works. So I order, okay, I'll have some fresh fruit, I'll have some pancakes, and I'll have an omelet. I wanted to test them, see what they would do.
Yeah.
10 minutes later, it was there. And all the other seniors that I was dining with had whatever they wanted. So it's really, in terms of management and cost structure, it's how you allocate your budget and where you put your priorities. So you can't do everything, but you can certainly
do lots of stuff.
Yeah, and then you can also, if somebody has dysphagia.
Yes, what is dysphagia?
So if someone has swallowing problems where they need pureed food, does the pureed food need to look pureed? Can you make food that's been blended, can you make it look appetizing? And there is the ability, and if the energy is there and the willingness to make food look delicious.
Okay, well, I'm glad you said that because I need to take a little break and have some squashed pears. Okay. Our guest is Dan Levitt from Tabor Village. We're talking about what's the best way to deal with the senior citizens who are beginning to lose some of their faculties. We're going to take a little break. Your opportunity for you to say hi to davidberner.com. We always welcome your emails and comments and questions, and also the opportunity for friends of ours who support this program to say hello here on Shaw Community Television Cable 4. Back in just a minute as soon as I open that can of pears. This program has been made possible in part by the following sponsors. The Trial Lawyers Association of BC. the Vancouver Courier newspaper. My new book about addictions, All the Way Home, Building Recovery That Works. Friends of mine who recently find themselves less and less able to take care of the big comfortable house they've lived in for years sold the house and moved into a private, very posh, very fancy place up at UBC. And I was amazed. Obviously, these people, the people who run it, have taken the model of a sort of first-class hotel, and I'm sure it costs a small fortune to be there, but how will most of us fare if we don't have a pretty good bank account? How are we going to manage in senior years, more and more senior years, especially if we're less and less able to make choices for ourselves? Dan Levitt has been in the senior care business for a great many years and currently the executive director at Tabor Village out in Abbotsford and an adjunct professor in gerontology at Simon Fraser University. We're talking about, now I forgot the name of the place.
The Hogaway.
No, not your place, but the
Harrow Park Center?
The private place.
Tapestry at
Tapestry at UBC, and they have one at the old Molson at 12th and Arbutus, and then they have them around town. I think there's one on the North Shore. That's an interesting model. It's a private for-profit model, but they sure seem to do a bang-up job. You know, a pretty fancy schmancy. Yeah,
they're very fancy, very high end, and there's a market that they're getting. And people who move into a nursing home are moving into nursing home because they need to be there.
Yes.
People who move into those properties want to be there.
Yeah.
And they have the means and they can afford to do it.
Yeah.
So this gets into that cost question is if people have the money, should they pay for it? And what happens in publicly funded facilities is that you move in and the health component is under the Canada Health Act.
Yes.
The hotel component isn't.
Aha.
So if we separate the two, is it reasonable to expect seniors to pay for the hotel component? And we've been doing that across Canada. That's been our model, and it's means tested based on income.
Yes.
We're not yet getting into the asset testing as they have in the States, but they may do that in the future.
So a place like Tapestry, they do offer medical care. They do offer, in addition to beautiful accommodation and fine meals and lots of coffee and recreational things, they offer care. But that care, you're saying that element is paid for by our health system? Yeah. To some degree?
To some degree.
Okay.
So they could probably bring in some home care that would be through Vancouver Coastal Health.
Okay.
Or they can pay for somebody privately to assist them.
Yeah.
And our big question is going to be with with a whole demographic moving forward, how are we going to care for all of them? Because we don't have more money to add to the system.
Yeah, well, it's interesting because Dr. Brian Day is a friend, and he's been, from Canby Surgery, and he's been a guest on the show several times, and he continues to lobby for acceptance of some private services. But it seems, Dan, to me that we already have lots of private services like this. I mean, we are saying to people who have the money, you want to live in a fancy care home, that's your business. And we will pick up, we as a body politic, we will share some of the health care costs. But if you've got lots of loot, we're going to want you to share some of it too.
And it's so the question is going to be, at what point, how far are we willing to go?
Yes.
Because what are we going to do in 20 years from now when all these people need care and services, and they all can't stay at home? There won't be enough people to care for them in their houses.
Yes.
And part of the solution has to be to build new facilities and to look at different ways of funding. I think that's really where communities will be looking at capital campaigns, looking at supporting these communities, as well as those people who are there, if they have the means, to supplement the revenue stream so that we can provide exceptional care to them.
Well, Dan, God forbid you should run for office. I'm sure you'd be elected, and I'd vote for you, but although we'd hate to lose you working on the ground level, you know, in real life. But let's say you became the health minister 10 years from now. You became the man in charge, pulling the levers for, you became the Wizard of Oz in Ottawa. What would you do in this regard? What do you think we can afford to do or must do 10 years from now?
It's an interesting question, and I was blessed enough to be able to interview our federal health minister for a journal recently.
Oh, good.
And in the interview, it really focused on that whole idea of innovative leadership.
Yes.
And I really think that is where the government can have the most influence, is on pushing the innovation agenda and looking at, we don't have more money in the system, how can we do a better job? And I really think that is where the example of the household model, which is being replicated in North America through something called the greenhouse model, where it's going across the states, and it's also in Canada, and they're replicating that kind of environment, and just like the Netherlands.
But you know, I can't remember if it was this morning that I was reading a piece in the paper about BC ferries and how, I think it was, and how we don't really have transparency and so on. But the point of the article was that BC ferries are an expensive proposition no matter which way you cut it, and they may or may not be well or badly managed. That's up for discussion, and we all love to discuss that. But every dollar that goes into fixing BC ferries is a dollar that isn't in healthcare. And healthcare and education are two of our biggest paychecks. Healthcare by far, what is it now, 50 cents on the dollar?
Just about, yeah.
Yeah.
And it'll continue to grow. So what we have to do is we have to curve that spending by finding the kind of new approaches to doing things differently.
And we not only have to be smarter, this is the challenge. We have to be smarter fiscally, but we also have to be more human. We have to be kinder. We have to do things that work better. This business, you know, the biggest single problem with the traditional old-style care home, for me, is not the furniture, not the hallways, the fluorescent lights. All of that's kind of a pain in the butt. The real problem is that you get cookie cutter service. You get the same attention to each person without a kind of really seeing this person in front of you. This is just another client.
And I think that the beauty now in the nursing home industry, right across North America and right across the Western world, is that there is a resident assessment tool, and we call it InterRI, where each individual person is assessed, and they each have their own essentially care plan. It's individualized, tailor-made to them, and then we are not just plugging them into the programs that exist. We're making sure that we're enveloping services and programs specifically designed for them that meet their individual needs.
I worked once as a volunteer in a respite operation for Alzheimer's, and the family brought the Alzheimer's person there so they could go out and have a day of quiet and get their hair done and go to a movie and relax and stop being doctors, basically, in their home. The problem with that setup, which I spotted within 5 minutes, was that everything was done in a group activity. And so what I did, I started culling one person out at a time and developing a relationship. One guy I played poker with, I played cards with every week. And he remembered each week what we were doing. You know, that's what I'm talking about. Look, in the same way that recovery work and addictions is about dignity, this is about dignity, is it not?
It's completely about dignity. And one of the things that I'm proud of at Tabor Village that we did recently was created a brand new therapeutic garden. And in this garden, the residents themselves, they plant the vegetables and the fruit. And on a Sunday afternoon, if you came to visit our Tabor Village garden, you would see family members together with a resident, and the resident is playing host. She's hosting her family there, and she'll walk down the pathway, they'll pick some berries, they might try a cherry tomato themselves, they'll water the plants, and it's all built around seniors' abilities, their strengths versus their disabilities. And it's a wonderful model, and it gives them a sense of taking care of something else instead of always being cared for.
We've come a long way, I think, from warehousing. Yes?
I don't think anyone's doing warehousing anymore. I don't think, I think that's a kind of an old term. I think there's a whole different model of individualized care. There's a whole movement called the patient experience movement, where we're interviewing family members and people who are in care that aren't too far advanced with their dementia, and we're asking them, how can we do a better job of what we're doing? When it works really well, how does it look? How can we create always events? How can we provide person-centric care? And as you described, by pulling the people out individually, that's what we'll do with music therapy, we'll do with spiritual care, we'll do it with mobility aids, with recreation, and it's really that gestalt, that whole person approach.
And when my family sends me to Tabor Village in a few years, like next Wednesday, I'll tell you what kind of patient I'll be. I'll be the one who says, "Don't bug me till I blow my whistle." Do you have that kind of patient?
We do, and those are the ones that we learn the most from.
Really?
We learn the most from the people who complain.
Yes.
And when we get our complaints, our job is to find out what's the root cause of this.
What's the deal here?
Yeah. Is it David?
Yeah.
Is David because David's difficult?
Yeah.
I don't think so. And we sure don't look at medication. We look at hugs.
Oh, very good.
So we measure not on the number of medications, but the number of hugs we give.
Well, we can have a hug after the show. No medication. Dan, thanks so much. You're doing great work as
Thank
always.
You
always do great work. You're a wonderful contributor to the community. And what I love about what you do is that you keep trying to make it better. Yeah, good.
Thank you, David.
Thanks very much. Folks, next week, I'm sorry to tell you that our guest will be right at the top of the headlines, and I booked him like 3 weeks ago, but given what happened in Paris yesterday, the nightmare in Paris, Marc Lalonde, who's also an old friend, will be our guest next week, and he's an international consultant on security matters. And originally I booked him to talk about the lone wolf syndrome, but we'll look at the Paris story, of course, as well. So thanks for being with us here on Shaw Community Television Cable 4. Good night. Good stuff, buddy.